All right, let's go ahead. Let's go ahead and do our HESI review. And let me pull up the PowerPoint. I sent this twice to you, so I know you have it somewhere. The last one was the last announcement that I sent. So PNR 204, this is the PN HESI review. Again, I got this right from your Saunders book. So this is part of your NCLEX questions and whatnot that we look at. So some of the things we need to understand is developmental milestones. And why do we need to know all of these names and numbers of stuff? It's because if you're looking at an infant ages 0 to 12 months, and we know those first 28 days, it's called a neonate, right? That's what an infant in the first 28 days is called. They go through so many changes, fine motor, gross motors, and we need to make sure, are they where they should be in that developmental time? If they're not turning over completely by 8 months, they should be doing that by 6 months. Something's wrong. We need to look. Maybe it's just putting in some physical therapy, occupational therapy, or even speech. And they do that even on younger kids. We know nutrition is important, right? Nutrition feeds the brain and it feeds the body, so the body can move and the nerves work, etc. If it's not gaining enough weight, we know we're not getting enough nutrition. That's why every single visit a child goes to a pediatrician, you do a height and a weight. You don't do that in the adult world, do you? I don't remember the last time they weighed me in an adult office. Now, urgent care ER different, but in a doctor's office, I haven't done it. I don't remember. I don't want to know, I guess. I guess that's it. Anyway, doubles the weight by 6 months. If it's not enough, we'll add more nutrition. If we're seeing it's way too much, we're going to look at what is that mother feeding that child and pull it back a little bit, because then too much, they're too heavy. They're not going to be able to support their weight, sit up, turn, roll, stand up, creep and crawl and walk, right? And then triples by 12 months. Their birth length is amazing how quick. The first 6 months is an inch every month, and it does increase by about 50% after a year. So soft spots, you have anterior on the top, posterior on the back. The one on the back, about 8 weeks is gone. The one on top, maybe about 15 months. And what's so great is that fontanelle, we can look at a lot of things that are going wrong with an infant just by seeing, is it depressed or is it, overfull, as I call it? Is it hydrocephalus or dehydration? It's one of the first things I look at with infants. Let me just see what's going on there. They should be able to coo. They should be able to look, when they hear noises coming. That moral is that also called a startle reflex, where they all of a sudden, when you hit the crib or make a loud noise, and it goes away about 4 months. I mean, we still have a little bit of that fright thing as we get older. Somebody comes behind you and screams in your ear. Yeah, you jump. But as infants, it's that just hands play thing. Head control should be really good by about 4 months. Turning over completely. It's abdomen to back and then back to abdomen. And 6 months they should. And then, of course, we're going to start playing peekaboo. So remember, fine motor is fingers. F fine, F fingers. It's all about that voluntary reflex and voluntary grasp. And then it goes into the pincer grasp. And by 7 months, they're not only voluntarily getting that rattle, they're putting it from hand to hand. And of course, in the mouth, where they explore the world, always in their mouth. We know that they start knowing the difference between who is the people they see all the time and then those stranger dangers, right? They call it stranger anxiety. They don't want to go to people they don't know. And it's because they have the comfort. They've built trust, what Erickson says, to somebody, grandma, grandpa, mommy, daddy, or auntie, or whoever. Should be able to sit unsupported at 8 months. That means no pillows propping. They're starting to crawl at 10 months. And then that little picking up one little Cheerio, putting it in the mouth, very fine pincer, should be about 10 months. And they can do that. They're going to be start waving bye-bye. And they're going to be able to put their feet in front of each other and quote, they call it maybe taking a step by a year old. I say this walking, my children and even my grandson, none of them walked by 12 months old. At 15 months, they ran. They never did the walking in between. And it's remember, as long as they're standing up, all the other developmental things are there, we're doing good. And of course, are they going to say mama or dada first, right? Mommy or daddy? It's always, oh, they said daddy first. Oh, they said mommy first. And again, remember, they're exploring their environment by their crawling around and everything in their mouth. That's why you got to be careful. Safety, safety. So you did a discussion question, separation anxiety, very important concept. Children initially, mommy has to go home and they can't stay due to, they have to work, they have other kids, whatever, or they have to go home, get clean clothes. They're going to be screaming and yelling, and that's protest. And then it gets to the point where they give up. They're saying, all right, they're not coming back. And then it's when they come, they're not going to pay attention to them. And that is those stages of separation anxiety. So some of the HESI things that they are looking as in length, birth length doubles by 4 years. We've already said sits unsupported 8 months. 50% of an adult's height, you're going to see that when a kid is 2. So if you have a 2-year-old, if they're this height, that's probably what they're going to be. I know that it's not all the time. I had a little tiny little peanut. Well, my grandson's one, but my son was this little tiniest little kid. That kid's 6'5" now. So that's just overall. It doesn't mean all of them are, okay? They're getting that dexterity.
Professor,
Yes.
can you please, excuse me, can you please explain this 50% of adult height by 2 years? Let's
So
assume if I am 5 feet,
you'll be 10
if
feet.
I am 5 feet tall, no, if I am 5 feet tall and I give back to my daughter at 2 years, she should be 2.5 feet tall. Is that what you're saying?
Yes. But remember, that's just a guideline. It doesn't mean it's for everyone. Remember, these are like an over, most of the children.
Okay. Thank you.
You're welcome. 2 to 3 sentences by 2 years old. They're starting to be able to get their point across. Scissors, you see them in preschool, right? They're 4 years old. They're doing it. Tying their shoes by about 5 years old. Today they don't even need to tie shoes. They got Velcro straps for everything, don't they? They make it really easy for us. But if they needed to, they would be able to do it. And my grandson's 7. He don't know how to do it, but he has pull-on shoes. Everybody does. Thyroid hormone therapy. Now, the one thing about hormone and hypothyroidism and children, the one thing that it doesn't affect like it does in adults with children is in children, you need it for growth. You need it for cognition. So how do you know if thyroid hormone is working? It's number one, their cognition, their motor skills. They're going to be able to hold their head up. And we're going to see that they're growing properly. Both of those things you're going to see. Growth spurts on the adolescents, we know 2 years before, it's girls and boys. That's why, like in 7th, 8th grade, girls are all taller than boys, if you ever noticed. And then all of a sudden in 9th grade, all of a sudden the boys are getting taller, right? I mean, I even remember that growing up through that. Temper tantrums are normal. Me, mine, I do. It's normal. I always say if they're having one, let them have it. Don't acknowledge it as long as they're not hurting themselves or others, okay? Adolescents, we know this is all about figuring out who they are. And they're pulling away from the family group. But remember, by the end of adolescence, they're either going to college or they're getting their job and moving out into their own little family groups, right? So they need to do this rebellion, although it's so hard on parents, okay? And it's just part of Who am I? Who am I going to be? Where am I going to go to school? What do I be when I grow up? Do I like girls? Do I like boys? All of this. Do I like short hair, long hair? What clothes? Do I like music? Do I like rock and roll? Do I like all of these things? These are part of what they're learning. So school age children, Erickson, always you're going to see an Erickson school age, always. And you're always going to see an Erickson, the trust, the infants. It's just part of one of those things I see on many, many exams to let you know, okay? School age,
So there is a lot of that, the theorists on there.
usually two or three,
Okay.
they're there, but I'm telling you the ones that I see most of the time. You'll see adolescence identity, you will see Erickson school age, and you will see the Erickson infant. Those are the ones I see most of the time. You might see a Freud about, anal time, potty training time, those very obvious ones, okay?
Okay.
Now, Erickson, this is all about giving them a task to do that challenges them, but they're able to accomplish it. As nurses, what does that mean for us? Well, you have a kid who's in the hospital, has to be there for a long term, let's say, because of whatever happened to them. Now, we will, they've got their family, and of course, their schoolwork's going to come in, all those things. But as nurses, we have the ability in pediatrics to get things like puzzles and paints and stuff that we could put at the bedside if they're able to do it, and we can challenge them. But would you give them 1,000-piece puzzle to do, a 7-year-old? Oh, absolutely not. What would that happen? That's the inferiority. I can't do it. Let's make it 100-piece to start with and work up, right? I mean, thank goodness for pediatrics, they have child life. And child life is the one that gets, I can tell you that down here in Miami, the Children's Hospital that we have, you should see the amount of toys that are donated for Christmas and for holidays and what they have on hand at all times when there's a kid's birthday and stuff. So they've got the resources for you to challenge a child. But remember, something that they can accomplish. Don't make it unreachable. So body injury, big thing. Always look at safety and always look at infection control. Two things that you're going to look at. So infants, you think that they're infants, they don't remember pain. They do. This is a misnomer that I've grown up in newborn ICU. My first newborn ICU job was back in 1984. And I remember to this day, we had this child that had something called Pierre Robin. So I had a tiny tongue that would fall on the back of the throat. The surgeon came with a suture, no sedation, and put the needle and sutured the tongue to the lip, no sedation. And I'm like, what are you doing? Oh, they don't hurt. They're not going to remember. Well, we know today we would never do that. We have learned that they do remember this stuff. Believe it or not, they do. Remember, toddlers don't like things that can hurt them, touch them, pinch them. Needles are big things. They don't like that. Preschoolers, they're afraid of mutilation. They're afraid that if they get a cut, all their body parts are going to come out and they're going to die. That's what they believe. School age children are really afraid that they can't control their body and do what they want to do. Remember, there are things they do well, their industry, they build their little industry, and then that inferiority of what I can't do. So they're afraid of that. And of course, adolescence is all about body image. Think about adolescence. They start, shorter. They don't have, they're gone through puberty yet, most adolescents. And then all of a sudden they grow real tall, and now they're going through puberty and they start getting curves. And of course, it's body changing. I'm getting pimples, right? I'm getting too fat, too skinny, too tall, whatever. Body image is huge. They're worried about what everybody thinks of them. Accidents are huge, all about teaching parents, how to prevent accidents in children. We know toddlers like to get in the back of couches. I call them the dive bomb kids, right? And like to jump over to the hassock, it's 4 feet away. But teaching them, things that we should let them try because that's the autonomy that they need to learn. But again, teaching them about safety and letting them know, the stove is hot, right? Or in the tub, making sure you're there with them. Now, pain, as I said, pain is now looked at very closely. Back, I believe it was the early 2000s, the Joint Commission felt that all age patients, whether children or adults, we weren't identifying if they had pain or not. And then we had to say, well, how are we going to say an infant? How do we know if an infant has pain, right? So what they came up with is a couple different scales. Now, there's 3 scales that are always looked at. And one is FACES. FACES is a picture of a face. It's called Wong-Baker's FACES. And preschoolers ages 3 and up, they can point to the face that they feel like. And I'm telling you, they tell you exactly. It's not like adults. What's your pain? I got a 12. And they're sitting there laughing, right? So we know children, they don't lie, they don't exaggerate. And then the other one we need to know, and that's numeric, of course, ages. You'll see some books 8 years, some books 9 years. It's the older kids. Then we have nonverbal. And nonverbal could be your cerebral palsy child, nonverbal and 18 years old. It's still a nonverbal child. And we look at their faces, legs, activity, crying, and consolability. And it works really well. And we can do pain scales. So always evaluating pain. So what are we going to do? Well, you always say pain, medicate them for pain, right? It's not all that. Sometimes it's sitting down next to a kid and letting them talk to you. Sometimes it's distracting them, saying, hey, what can I do for this child? Maybe let's get some stickers. Let's get, an iPad in here, something. Infants, a pacifier takes away pain all the time. I've mentioned to my class, my grandson had a circumcision with a little sugar water on a pacifier. And yes, he cried, but not from the pain. He cried because he was strapped down in order to do a circumcision. That's why they cry. Once they're taking up, they're doing well, okay? But distraction is a big thing. Also, hot packs, cold packs, repositioning. You had abdominal surgery yesterday and you're flat in bed. Elevate the head of the bed. Take that pressure off that tummy. Those things are just as important as the medications, okay? Always verify, especially if you're doing narcotics. Always, that's a double check medicine with children. Are you giving the proper amount and making sure it's safe? Always vital signs before and after, making sure, especially with narcotics, respiratory rates, right? And children that are 5 years and older having huge surgeries can use that little push the button when I hurt. And the anesthesiologist will dial in what's safe for that child there, okay? And then at all possible, don't give IM injections. We can give IV as safely as IM, and then the kid's not getting needle. As down here in Miami, they say, no pinche, which means don't give me a shot. They're afraid of it, many of them. So IV, they don't feel it. But remember, once you give IV, it's in there. Common communicable diseases. Well, we have measles and we have vaccinations. Now, do you need to know when all the vaccinations are? No. You need to know live vaccines. You need to know hepatitis is the first one, hepatitis B, first one that we get at the hospital, okay? And we need to know what do we need to look for because not all children get vaccinated. You still have some parents who don't believe in it, okay? So knowing what things look like rubiola with Koplik spots, that's what you're going to see, all right? There's varicella zoster, chickenpox. Again, it's a live vaccine, all right? And this is all air. So if I was a nurse and I see this like rash, and we call it at all different stages of healing, that's probably, your chicken pox. Make sure you put a mask on, your child a mask, and get them into a room where they're not spreading it all over the place, okay? And we know that they can be contagious before they break out with a rash. German measles, this is the one that we worry about pregnant women. So if we're in a hospital, we have a diagnosis, if there's any nurse or anybody in there that's pregnant, I would tell them just to keep away. I don't have to tell them why. I just tell them just please keep away. Always remember children with communicable diseases. I've mentioned this. Isolate them. It's better to isolate and you didn't need to than not isolate, and you should have done it because you can spread chickenpox to a whole emergency room, okay? Type thing. So be very careful with that. Always remember, we don't give aspirin. It's ibuprofen and acetaminophen. And the only time we give aspirin is Kawasaki disease, right? And that's your cardiac thing. A lot of times, like chickenpox, they itch, right? Get those nails
Excuse me,
short.
Professor.
Yes.
Excuse me, Professor, if I can say something. For that Kawasaki disease, I remember when I took the last SC, it came, and they asked that particular question, when do they give aspirin?
Kawasaki. And we give it.
Yes.
We give it because it thins the blood and prevents clots.
Okay.
That's why. It's like giving Coumadin or heparin. It gets the blood flowing through the coronary arteries, because in Kawasaki, that's what we're worried about. Thank you very much for that. Again, anything that itches, cut their nails, mittens if you have to, and soothing baths, and sometimes lotions, depending. Of course, sometimes we're going to give some Benadryl for that, for the itching. There's other stuff we can do. Some is topical and some is oral. And again, because they are itching, preventing infection, washing their hands. Now, pediatric nutrition. We know they're getting proper nutrition because we know they're gaining weight, because every time they come for all their immunizations, at 2 weeks, 2 months, 4 months, 6 months, 1 year, 15 months, 18 months, right? These are the times we're giving all these immunizations. We're weighing them, and we know they're getting enough and the weight is doing good. Remember that there is times where children do not eat what they should. Remember, toddlers go through like this anorexia, we call it. They barely eat, right? So they're not getting vitamins. So it's A, C, B6, B12. Sometimes they need to have replacements for that. Now, adolescents, they're growing that big growth spurt, aren't they? Just like infants, we need to feed them so that they can go with the grow. Adolescents, what do they usually do? They stop eating because they're too fat and they want to be skinny, right? They grab a power bar and a bottle of water, and they run out for the day. There's no time. So they're not getting their calories. They're not getting protein, zinc, calcium, and iron. And a lot of this is due to not eating right and that growth spurt. Remember, it's 25% of their growth. Dietary history, just keep a record. It's always a diary. It's always going to be an answer to a question. How do you figure out if a child is eating right? Do a minimum of a 24-hour diary. What are they eating? We want to know. And, ask them how many times are they eating things like meats and milks and fruits and vegetables, and it's quite amazing that some of these kids, aren't eating these things, regularly. And we know families today, mom and dad works. It's hard to have a dinner at one time for everybody. And that's just reality. Diarrhea. Biggest complications, dehydration. Dehydration is dangerous in children. You will go into a metabolic acidosis, shock, and death. Now, what do you see? What do you see when a kid does not have enough fluids? Well, an infant would have a depressed fontanelle. Really easy. It's the one thing to look at. But listen to the heartbeat. And if it's faster than it should be by a lot, it's going to be dehydration. You're going to see elevated heart rate, decreased blood pressure. You're going to have poor capillary refill. Urinary output's going to be nothing. And because you're not getting blood flow to the brain, you're going to have very weak, lethargic child, mental status change. Poor skin turgor. Take an infant who's dehydrated and they're cry. They don't have tears. It's the saddest thing to look at. No tears. And of course, if they're in the hospital, we're watching them, they're going to be having weight loss. And you'll see it. That's why anything that's doing with fluid, dehydration, the way we treat it is intake, output, daily weights. We want to make sure that they're getting enough fluids and that their weight is increasing now because now you're replacing fluids, okay? If we are going to be given extra fluid to a child, which many times we will to try to catch them up quick because we want that blood flowing around to all the vital organs. Remember, we're not putting potassium in any IV that we're going to run really quick. Potassium can kill your kidneys, okay? Potassium on a dehydrated child that's not urinating, it's just going to elevate it, and it could really, really hurt your kidneys. So we don't, until we have a potassium level or until they're urinating, we won't put potassium in the IV. Same thing with sugar, dextrose. It should be 1 to 2 mLs per kilogram per hour. In the adult world, they say 30 mLs per hour, right? Minimum. Well, children, it's 1 to 2 mLs per kilo. Diarrhea. Now, vomiting, you're vomiting. You can't take oral rehydration. But in diarrhea, we can give oral rehydration. And we would do that with Pedialyte, Powerade, Gatorade, right? Let's get that fluids in. Again, it's the same signs and symptoms. Elevated heart rate, decreased blood pressure. Again, it's just dehydration we're concerned about. And with this diarrhea and vomiting, always check your electrolytes. You're losing fluids like crazy, right? Fluids like crazy are being lost. When you have diarrhea, you're losing a lot of alkaline because your digestive enzymes are all alkaline. So when you're losing all that alkaline, what is left? Acidosis. So you'll be placed to metabolic acidosis. Okay. We do check the specimens, culture sensitivities, C. diff, and all sorts of crazy things. So making sure that we do check them, send them to the lab properly. And again, universal precautions and wash your hands. Now, child abuse. Now, I wish I said I never saw a case of child abuse, but I've seen quite a few. And one is worse than the other. So, as a pediatric nurse, your job is to keep a child safe. And I know I've had children come in, a 3-month-old, and this is a true story. 3-month-old came in, mom said there was behind the ear some yellow and green discoloration, and when you touched it, the baby cried. Well, the first thing I have to do is weigh the kid, right? So I picked up the baby, it was a boy, and I felt my fingers squish the skull. And I was doing it softly, didn't mean to. He cried, put him down, got the weight, did the rest of it. Immediately got this kid. I spoke to the ER charge physician, got him over for x-ray, and it was a child abuse case. So it does happen. So one of the things when we are looking at children, are these injuries what the parent says it is? Or like that yellow-green bruising, we know that's been there for a week, right? With just the coloration of those bruising. So we know there's suspicion going on there. We can see bruises, welts, fractures All stages of healing is the big thing. That little boy not only had a fractured skull, he had a fractured femur, fractured ribs, and a fractured humerus. The father had smacked him in the shower surround. He was crying and it wouldn't stop. So he figured, well, let me just smack him around the shower. To this day, it makes me sick. But I know that the authorities were called in and that kid's safe today. So remember, looking at a child, are they in, kids get into stuff, they're dirty, they come to the ER, yes. But is it something that is more than normal, okay? As a PN, you are legally required to report it. Go to your charge nurse, go to the physician, tell them what your suspicions are, and it does need to be reported just to keep the kids safe. Now, poisoning, we know we have poison control. Anything that goes in, first thing an ER triage nurse does is call poison control. We get what's gone on, get their vitals, call in, they tell us the treatment. We should never have a child vomit, okay? Don't have a kid vomit. It is not recommended anymore, okay? So what do we teach parents? Call poison control and then get the kid to medical care. Respiratory distress. This is always a big topic, always covered. Respiratory. You have a kid can't breathe good. What do you see? Well, they get to the point of restless, they're hypoxic, or, something's going on. But that increased respiratory rate, increased pulse rate, they're sweating, diaphoretic. In infants, you'll see little flaring nostrils. And in infants, your younger ones, at the end of a breath, you'll hear a and that's called a grunt. When you have a young child, baby, who is flaring nostrils and grunting, that child is about to code on you. So that child needs immediate medical attention, okay? Of course, we'll listen to the breath sound. You have rales and rhonchi, and of course, shoulders up and their heads are bobbing. All of these things are going to show you that there is a problem with respiratory. You're not getting oxygen. And of course, cyanosis. Now, asthma. Asthma is you get air in easy, not a problem. But it gets into the bronchioles and they're swollen and you can't get the air out, okay? So what we use is our rescue, right? That fast-acting bronchodilator, and that's albuterol, Preventol, whatever the name is. They're all the same thing. Those are your rescues. And then giving steroids, whether IV, PO, depending on the child and how bad the asthma is. If they can take oral, we'll give them liquids. Of course, fluids are always important because fast breathing, mucous membranes are getting dry. You're losing fluids quickly, aren't you? If they need oxygen, make sure that we put it on them. They want an O2 sat of 95 or above. That's okay. Some textbook says 90, doesn't it? But the HESI book says 95. In children, a lot of the time, they use things like your Singulair, the Montelukast will be put there, and then levoalbuterol, which is, it doesn't affect your heartbeat as much, okay? It's just like albuterol. Now, another respiratory issue, but it's just not respiratory. It's mucus clogging the lungs and it clogs the digestive system. So it's two places. So you're worried about the lungs full of secretions, right? And then you're worried about nutrition because your nutrition is being lost. You're going to lose sweat. It's going to be salty. I tell students that if you licked a child with cystic fibrosis it would be extremely salty. Now, don't do it. I'm not telling you to do it, but I'm just saying that's what it would taste like. And it's a lot to do with fat absorption, and it has to do with these really horrible stools that occur because of the fat. And this is the one that we give the pancreatase enzyme to. And we give it right before we eat meals and snacks. So if a child with diagnosed with cystic fibrosis needs more calories, 150% more. And the reason is they don't digest fat, and fat has the most calories in it. So you need to replace that with carbohydrates and proteins. So what are we going to do? What's your job with cystic fibrosis? Well, it has to do with the lungs, so respiratory status, and looking for infection. Before they eat, we're going to be giving their enzymes. Remember, we can, remember anything extended, we don't chew, but we can sprinkle it on a little food. They can take it. Don't put it on a lot because you want to make sure they get it enough and get that in there first. And remember, they're losing those vitamins, not just absorbing the fat in the food. Fat vitamins are also being lost. These children need absolute, unbelievable pulmonary care, chest PT, physiotherapy. They need their nebulizers, sometimes oxygen, to get those lungs from being thick and clogged up there, okay? And again, being careful to prevent any sort of infections. So it's infections for your lungs and giving enough calories. And it's all about getting them the nutrition that they need, okay? These kids, yes, their lungs aren't going to be as open. So this kid wouldn't be in track running a mile. This kid would be doing something that would be less aggressive. So respiratory will give lungs. What will give lungs? Will give oxygen, right? The newborn infants, that little plastic hood, a little oxy hood is great. Works well. They can look around. They can still suck on their pacifier or their fingers. We know that the little nasal prongs are O2 sat. Very tiny amount of oxygen can be given. And then tents. Remember with the tents, sometimes the kids get scared. You can go underneath the tent with them, and make that comfort there. And again, because it's moist, keep the kid dry. You might be changing that t-shirt or that gown frequently on that kid. Monitoring their O2 saturations with a pulse ox, and occasionally, we don't like to do too many because it does hurt, do a blood gas on them. And know that children 83 to 100 on their oxygen and their ABGs are good. Now, epiglottitis is life-threatening. This is a real and true emergency. And epiglottitis is that epiglottis covers the trachea and air can't get into the lungs. It's all inspiratory. And it's caused by Haemophilus influenza. And this is swollen and you can't get air there. This child is drooling and you'll see them inspiratory stridor. And this is one that you are not going to put anything in the mouth and look in there. It can cause more crying, the child be more upset and create an obstruction, and now they're really not going to breathe. Bronchiolitis. What's the other name for bronchiolitis? RSV. So you might hear the name bronchiolitis, or you might be hearing RSV. They're both the same thing, okay? Again, we don't know if it's a virus, what's going on. Initially, you're going to isolate them in their own room. And again, good technique by you, which is washing your hands, wearing a mask so that we don't spread it around. Keeping the airway clean, and especially before, if they're able to eat. The one thing I always tell parents, do not over use suction to keep the nose clean, because sometimes overusage causes a buildup of mucus even more, okay? Now, some infants are really already weak. They do not have the strength. Let's say they're a cardiac child. This cardiac child could have, an RSV. And RSV is they close up their airway with mucus and they become dyspneic. You know, especially the younger kids, the infants, they're obligatory nose breathers. Now, they can't breathe. Their nose is full, right? Puts an undue stress on them, whether they're premature, congenital heart. So what we do is we give Synagist. The other name is called Bevizumab, and it's given once a month, usually from winter to spring. And that it's an immunization. It protects the child from getting RSV. So bronchitis is keeping that airway clean and keeping them with fluids. So respiratory disorders, are some need to come to the doctor ER and some don't. Again, teaching them, what to expect, what is abnormal, especially with a child who has conditions. If you have a 1-year-old and all of a sudden the respiratory rate is 50, well, that one you need to get into some sort of care, to the physician's office, urgent care, or to the ER. So again, our job a lot is teaching. Now, ear infections. Ear infections get mucus in your upper airway, and then it goes up the eustachian tubes. It's like the area of least resistant. If it was a heart, I'd say it's shunting, but it's not a heart, but it does. It goes, least resistance goes right up into the ears, and it hurts. So how do we take care of this? Well, these children hurt. They're in a lot of pain, and some have fevers, and actually some don't. So giving, acetaminophen, Motrin as they need it. And of course, it's always an infection. And upper airway is usually staph. So giving antibiotics as they need. Sometimes warm compress to the ear helps. Sometimes the kid doesn't want anything to touch it there. And sometimes teaching these parents, give the kid some ibuprofen just for the pain. I mean, parents think, well, they don't have a fever, I can't give it. Well, it's also used for pain. And sometimes these kids have come into the ER and they're crying and they're holding their ear and they don't want a hot pack. I give them Motrin, ibuprofen. In 20 minutes, this kid is a new child just by medicating for pain. Tonsillitis could be viral, bacterial, or strep, right? We know that there are two big conditions that is a big problem. If we do not treat completely, do all the antibiotics, and then check to see if it's gone by then, if they don't need more antibiotics with their pediatrician. It can cause the kidneys to shut down and acute glomerulonephritis. Also, it can cause the rash and fever and sore throat, general malaise, and then it can hit the heart valve, right? Once it hits a heart valve, that damage is permanent. The other thing is what we call chorea. It's that jerky sort of movements. Now, even that can be reversed, but and we reverse it by, let's treat the strep infection that we didn't treat the first time. Let's antibiotics, but most likely it's going to be for a month or so. It's going to be longer than it would be if they did it the first time. Now, tonsillectomies, we know that they're cutting off the tonsils in the back of the throat, and then they cauterize the areas. Any surgery like that, I mean, especially highly vascular, make sure that we check bleeding times. Some children have been ibuprofen a lot, and it can cause prolonged bleeding times, just ibuprofen. So make sure that they, before they go to surgery, we can tell our physicians. And sometimes it's a nurse who remembers these things. It's not just the physician who does this. We lead them along a lot. Say, oh, could you order this for this kid? I heard that they've been on ibuprofen for the last month because it's been hurting, etc. And sometimes you can save a bleeding episode post-operatively. So home care, warm gargles, well, very slight, just the rinsing of the mouth. You don't want to gargle like crazy. Ice chips is usually the first thing. Nothing red, no juices, Pedialyte, Gatorade, any of those. No, we don't want it red. But ice is usually comforting, and then acetaminophen. And sometimes this ice bag on the throat helps if the kid will keep it on. Signs of postoperative bleeding that could be a problem was that frequent swallowing, or they vomit and it's fresh blood. And you hear this all the time. It could be dripping. A story which is real. I had a little 6 or 7-year-old girl 1 week post tonsillectomy came into the ER vomiting liver-sized clots of blood. They dislodged the scabs and it caused it bleeding. This little girl, I had to rush to the trauma room and she was in hypovolemic shock. She lost so much blood, she was going pale on me. Heart rate was 200, so we got an IV in her, gave it quick. I picked her up and carried her and got her in there. And I said, hey, get an IV, let's go. And we took care of it and got the physician. So tonsillectomies do bleed and it can be serious. So respiratory disorders. Number 1, what are bronchodilators? What are they used for? Dilate the lungs. Let's breathe them. It's their rescue. What do you see with asthma? Well, a kid's going to be dyspneic and expiratory wheezing. Get the air in good, but then you're as you try to get that air out of there. Nutritional support, remember, high calories, high protein. Genetic counseling, making sure parents know what are their chances for another child if they want one. 7 signs of respiratory distress. We can go on and on. The answers were earlier. The care of a child in a mist tent. Remember, keep them dry. And sometimes it's scary being under that plastic. Parents go underneath them with them. There's no problem with that. Parents can get the oxygen and moisture too. If a child comes in with epiglottitis, they come in the tripod position. It's like an old COPD patient leaned over. They're trying to find a place where they can breathe through that epiglottis covering the trachea, okay? Otitis,
Professor, what is mist tent?
What is a
Describe
mist tent?
mist
It's an
tent.
oxygen tent. It's plastic.
Oh,
It goes over their head, gets tucked into the blankets, and they put moist oxygen flows in
okay,
there.
okay.
And
Okay,
it
thank
helps
you.
with respiratory distress. They don't use it a lot, but they use it sometimes, okay? It used to be used a lot more when I first started nursing.
Okay, thank you.
IV important. IVs are important for a child with increased respiratory rate. Well, if you can't breathe, you can't eat. And we know dehydration is extremely dangerous in children. So let's keep those fluids going. Chronic otitis media. If you're hurting your ears all the time, you're going to hurt your hearing, right? And those post-operative complications of tonsillectomy is bleeding, right? Bleeding. Now, your favorite area, congenital heart. I think every single nursing student say, I think hearts are the hardest because it's not like adults at all. Now, we have different sort of heart defects. One that the oxygen is depleted and some that they're normal. Oxygen saturations are good. Now, you have a child who has a cyanotic heart disorder. And I use the example of a hypoplastic left heart, most severe of all the congenital defects. Even tetralogy of Fallot, congenital heart defect, Well, the body's pretty neat. And what it says, you know, I'm going to produce some more blood cells. And I'm going to have those blood cells carry oxygen and iron to the body. Well, there is no oxygen because the heart doesn't oxygenate the blood. So even if you make more cells, you are not increasing the oxygen saturation. Polycythemia is the body. I tried, I'm doing something. You can have hemoglobin hematocrits of 18 and 54, 19 and 57. I've seen them that high, very thick blood, because the body keeps trying, but it doesn't work because the body can't get oxygen because of the way the heart and the lungs, they just don't work together well. Now we're going to do an echo, an EKG, of course. What are we going to see? Signs and symptoms. Well, you know, at birth, sometimes we know with, you know, today's advances, there's usually very infrequent surprises. We're usually aware this kid's going to be born and has a cardiac condition. But what would you see if you didn't know? Well, the heart's not going to beat the way it should, not going to sound the way it should. You might hear a murmur. You're going to see some cyanosis. Clubbing is something that don't happen till later on in life. It's when your fingers get, you know, square tips on the end type thing because of lack of oxygen to the tips. Now, the biggest sign and symptoms of a child that has a cardiac condition that hasn't been diagnosed immediately at birth is poor feeding, poor weight gain, failure to thrive. When you see that, it is probably the heart's giving up, the child's going in congestive failure. I have seen this many times with coarctation of the aorta. It was missed at birth. And that's that kink in the aorta, and blood goes back into the left side into the lungs. So you're filling up the lungs with fluid here. And you would diagnose it by checking pulses in the lower extremities, but maybe there was some, you know, just enough to get by. But again, when you start seeing poor feeding, poor weight gain, failure to thrive, these children, we need to be checking them for something. And that respiratory infections frequently could be congestive failure that we're just diagnosing as respiratory infections. And this activity intolerance, which causes poor feeding, poor weight gain, et cetera, et cetera. Sometimes it is an infection during pregnancy, but a lot of times it's other stuff too. So you need to know normal heart rates in children. As they grow up, we know the heart rate starts high. Newborns, 140 to 160 is normal. By 1 year, it could be 100 to 120 is normal. And we know when we become adults, it's 60 to 100, right? And that's what. One of the things about the heart rate, and it's one of the things I always check when I'm trying to rule out things, is we know if a kid has an elevated heart rate, are they dehydrated or do they have a fever? What, or are they just crying and they're anxious? Knowing why their heart rate's elevated, and then we can treat them. So with congenital heart defects, always, and sometimes we have to put the formulas, if they're on iron fortified formula, usually what you take, Enfamil, Isomil, all those things are 20 calories per ounce. Do you know we have some formulas that are 30 calories per ounce? So they can drink less, still get the same amount, and they're not going to be tired out as easy. Also, there's way to fortify the breast milk. There's breast milk fortifiers there, okay? So frequent smaller feedings and then that higher calorie formula, or we fortify that breast milk, can help getting extra calories without that effort. So sometimes congenital heart children, they're just so weak that we have to put in a feeding tube. Remember, what does an infant do to soothe, pacifier. Always remember, if a kid can't eat for whatever reason, let them have that self-soothing. Give them that pacifier, okay? Very important. Now, heart failure. And as I said, this is a lot of things that we see with congenital heart defects. The heart's not built right, it's not properly, it gets tired, gets weak, and it can't pump the way it should. And this is what we see. Basically, heart failure ends up in congestive heart failure, which means your lungs will fill up with fluid. You're going to see that tachypnea, tachycardia, they have no energy. They're not getting oxygen. Their lungs are full of fluid. You might see them cyanotic or just pale looking, that grunting, wheezing, edema, diaphoresis. And if you were to put your hand underneath the right rib cage, sometimes the liver drops down because fluid, it makes that liver go down. And you can actually feel the liver. I felt it quite a few times. So this is a fluid problem, isn't it? The heart's not beating right. What's our major priority? Intake, output, daily weights, right? We want to see, are we getting that fluid off that child? So vital signs, the heart rate should come down. Respiratory, it's going to sound better. It's going to sound clearer. The respiratory rate's going to decrease. I mean, whenever you want to breathe easier, elevate the head of the bed. As simple as that, right? Give oxygen as they need. And then digoxin is used in newborns. Very, very safe drugs. It's micrograms per kilogram. And there's a liquid. It's actually minty. I've seen it, and I like to know what I'm giving my kids. So I smelt it. It's minty type. And they drink it. They don't worry about it. And of course, furosemide, your diuretic. Strengthen the heartbeat, slower and strengthen it so it squeezes well. And then diuretics. Let's get rid of that extra fluid. And we're going to be watching their weight, intake, output. Now, if they were older, it would be a low sodium diet, okay? So usually the younger kids, the formulas, etc., we don't worry about it. If we need to give them a rest, we're going to gavage feed them. And then what is their defect? What do we need to do for that? Very important. One of the things that as nurses, there could be 4 scales on a nursing unit. We have found that there is some variance, right? The doctor's office always weighs you 10 pounds heavier, doesn't it? When you go there, well, some of the scales in the hospital, they're not all the same. We'll label them number 1, 2, 3, 4, and we will write down what scale did we use to weigh that child so that we have that consistency. And it should be same time of the day. It's usually the night nurses do the baths before the morning shift comes in. Sometimes we let them wait. Of course, parents want to do them, some of them. Now, rheumatic fever, this is all about that strep, right? How do we treat it? Well, we're going to be giving antibiotics for long term. And we might, with a valve issue, give aspirin because we don't, again, want the clots there on that valve. I've not seen it, but I know sometimes it can be done. And there's our Kawasaki. We talked about it. It's the vessels. It's an acute systemic vascularitis. The vessels get all irritated and little microemboli build off, and you get many times aneurysms in the coronary artery. Very dangerous because that aneurysm could blow and that would cause the child to die because that's blood flow to the heart. It's a heart attack and then blood going everywhere in the chest. What do you see? Well, I love the big red glow in the dark eyes. I think that's the most distinctive thing, but you don't always see that. And usually these kids, they're been sick for a week by the time, you're seeing them. Like for me, as in an emergency room, I wouldn't be seeing them till like they were a week being sick. They've gone to the doctor, they've gone to the ER, urgent cares, and these things are, getting, what's going on. You might start to see the hands get swollen, they might start blistering, or they might crack. Strawberry tongue, and it looks like a strawberry. And again, that red eye. Treatment, IVIG, aspirin, and the aspirin again is to decrease clots. It's to thin the blood. And, we're talking about a heart. We're always, worried, especially when there's something that could be stressing it, like that aneurysm, making sure intake, output, daily weights.
Professor,
Now,
so for romantic fever, we also give aspirin, right?
yes, the book
Okay,
says
both
aspirin. As what
aspirin,
I
okay.
said, I've not always seen it, but it is documented in the book, yes, to give it.
Okay.
Now, shunting. What is shunting? Well, let's describe this as the right and the left side of the heart. So, what happens? The heart beats, it squirts blood out of the aorta, goes all the way around, all over where it has to go, and then it just gets back to the right side. So the left side is high pressure, and the right side, it just gets there, low blood pressure, any flow pressure. Now, if there was a hole between the atrium or the ventricle, blood would go from the left to the right, shunting. Usually in a heart, you can't go wrong saying it's left to right, because you have big flow into the left side and minimal to the right. Now, tetralogy of Fallot. This is the pulmonary artery. It gets kinked, blood can't flow up there. When it can't flow, it stretches out that right ventricle a little bit. So you have what you call the hypertrophic right ventricle. And you'll also see usually a VSD, a hole on the bottom chambers. Ventricular septal. Septum is the division there. Could be a hole there, okay? And then the fourth one is the aorta pushes over. They call it an overriding aorta. How do we treat tetralogy? Knee chest. And the reason is there's a flap of something that covers that pulmonary artery. And I've seen it go O2 sats from 100 to 10 in less than a minute. 100% to 10% O2 sats. And I took the child knee to chest, and it changes the pressure between the peritoneum and the chest. And it will pop open, that pulmonary artery and start the blood flow in there, okay? Older kids, they might do they'll just squat. And there are some older kids that they haven't done. Now, ditch toxicity. Well, what do you know about adults? Well, in infants, you might just see vomiting and a lower heart rate, right? Other things that you're going to look for, a ditch level, if we have one, and your potassium. And cardiac cath. What is a cardiac cath? Well, cardiac cath is when we take two catheters, go in the right femoral artery and vein, and we go up into the heart, insert dyes, and we look at the heart, what's going on in there. Now, the biggest risk is bleeding when we're done. Because, it could be the size of my pinky, a femoral artery in an infant. Can you imagine if that scab popped off, how quick it could bleed? And it's an artery, so it's squirting. So that is the biggest thing, actually, with your cardiac cath. Remember, rheumatic fever is valve issues, usually mitral valve, and we use penicillin for rheumatic fever. Now, neuromuscular disorders, Down syndrome. It's the chromosome 21. Now, I'm telling you, there's 9, 11, 13, 15, and 18, but for your purposes, 21. It just means a child's a Down syndrome. What do we see with Down's children? Well, you're going to see many times they have as simple as a VSD, ventricular septal defect, but they could have truncus, They could have AV canal. You don't need to know what they are. They're just congenital defects. Blood's not flowing the way it should. Because of their nose, they have a lot of respiratory infections because it doesn't allow mucus to get out the way it should. They have trouble feeding, they're delayed cognitively, fine motor, gross motor, and they're extremely hypotonic. And one of the things actually is leukemia. They're at higher leukemia. Now, Down's children years ago, we didn't really teach them. And we have found today that many Down's children are teachable, educatable, and they can go to college, get careers. So wouldn't we give them, let them be the best they can be? Cerebral palsy. Many times it's due to maternal infection or they're born at a low birth weight and they've had a hypoxic or an anoxic episode. And sometimes, with CP, it's mild to extremely severe, depending on what's happening. So some of these children will be impaired cognitively. Some will have seizures because of the brain episode, what happened. And some of them, they do have a failure to thrive, and that's your severe. One of the things with children with cerebral palsy, their jaw, they don't know how to suck and swallow. That's why speech therapy is needed to teach them how to drink a bottle. Many of these do go to these prescribed daycares just to have them learn how to suck and swallow without aspirating. And again, one of the big things is having them sit up when they eat. Spinal bifida is also called myelomeningocele. One of the complications is myelomeningocele is that big blob on the back of a child, which means the bottom of the skin didn't close and the meninges and the nerves ripped up and are on the outside there. And these children end up getting the nerves in their lower extremities get to be really damaged. Our biggest concern is worrying about the bladder and are they urinating? Because we don't want that bladder to fill up because their autonomic nervous system don't like that, and it can create things like symptoms of hypertension, etc. So making sure that we do those every 4-hour caths or whatever they need with it. One of the things that we put every child born with this on the back, this, meninges and nerves, we put them on latex allergy. And, we'll always be concerned, does that spinal cord and the brain work now? Is fluid flowing the way it should? And if not, these children might need, because of hydrocephalus, a ventricular peritoneal shunt. So as I said, the hydrocephalus, it's something that happened that the flow doesn't go the way it should. So this is the one that we would put in the ventricular peritoneal shunt. How would we know this is going on? Well, in younger kids, we're going to be doing, head circumferences, and as they're in the doctor's office, if by a year and a half the head is still bigger than the chest, there's a problem because the chest is supposed to be more than the head by about then. And it would be something that we'd be looking for. We know that shock, increased pulse rate, decreased blood pressure. And when we see increased intracranial pressure, that fluid building up, that hydrocephalus, you're going to see the pulse go down and blood pressure up. So it's opposite of what you think, and it'd be something that we would look for. So one of the things about looking at neurostatus, what was the child before you have concerns about increased intracranial pressure? Is this normal? Are they acting normal for them? We don't know what their normal is. The parents know it. So we should ask. With increased intracranial pressure, we do put the head of the beds elevated, whatever the doctor says. Now, because of the pressure, we're always worried about seizures. And then when they're done with that ventricular peritoneal shunt, behind the ear, there's this little pump looking thing. We never, ever, as nurses, ever touch that. That's only for neurosurgeons, okay? Never do it. It's for them to do it. And because you're draining fluid to the belly from the head, you're going to be doing head circumference, abdominal girth. Now, seizures. When we think of seizures and we think of this grand mal, we know that's the tonic-clonic, right? That's the arms, the legs, usually foaming at the mouth, vomiting, and loss of consciousness, the post-stictal type thing. So there's different type. Tonic, the stiffness, clonic is the spasm, and then there's some kids and adults that just will stare. And you're talking and nobody home. And that's part of it. Or it could be just an eyelid going or a finger going. They're all different things. And there's what we call the drop attack. All of a sudden they drop on the floor. And these all can happen. Now, medication needs to be taken and they need to be compliant. Many of these medications do have lab values to look at where are they, for instance, when you look at phenytoin, dilantin, our level should be between 10 and 20. And if it's not, we need to give them enough, catch them back up. But it's something that we need to really teach these parents to make sure that they know they have to, give it, be compliant, because they'll have breakthrough seizures. Absolutely. And we know in a seizure, what do? We turn them on their side, right? Protect them from injury, anything in their bed. If we have a chance, we're going to pad that side rail, and we're going to call for help. Bacterial meningitis, an infection on the meninges in the brain. The only way we can diagnose this is through a lumbar puncture, because viral and bacterial both present the same. So you don't know until you see it. Now, bacterial absolutely needs antibiotic, and that's the priority, making sure they're given on time. And these children will have headaches and they will have fevers. So antipyretics will be given. Now, one of the things with bacterial meningitis is that they are contagious until 24 hours after the antibiotics have been started. So know that for you, protect you. Placing them in a nursing unit, very important. Put them in their own room. Usually it's one of those reverse airflow rooms. And then their eyes, lights, sound, noise bother them. Make sure it's quiet and it's dark, okay? And anything that affects the brain, you always worry about seizures. Because we worry about too much fluid in the brain too. Again, intake, output, daily weights, right? Again, fluid balance, always look at it. And they do give the hip vaccine, and that's to help prevent a bacterial meningitis from the H influenza, because it can go to the ears, it can go to the trachea, and it can go to the brain. Anything is all connected. Lungs is all connected. So inappropriate antidiuretic hormones or diabetes insipidus in the brain, pituitary, the posterior side looks at fluid balance. So how do we measure fluid balance? I've said it 4 times already. Intake, output, daily weights. If we're seeing too much fluid going out or too much coming in, and we can't figure out why, and we're seeing fluid in the brain, all of these things will increase the problem with seizures. So something to look at. Reye syndrome is due to aspirin, right? It could be with the influenza, chickenpox, but that's why we do, and it's metabolic too. We don't give aspirin. A brain tumor. Well, signs and symptoms. We've talked about headaches, bacterial meningitis, right? Seizures, well, brain tumor. What do you see? Well, you're going to see a headache, and you're going to even see them wake up at night because their headache hurts. That's something that normally doesn't happen, and especially on waking up in the morning, headache. Vomiting, which has nothing to do when they ate, okay? And they're not nauseous, all of a sudden they're just vomiting. You might see that loss of consciousness, change of behavior, vision problems, the head tilted. I've seen that one too. In infants, that fontanelle and the sutures are getting wide because it's occupying space. And then, of course, how they walk in the older kids. And they're not doing what they used to do. They've gone back developmentally. Now, one of the things about brain tumors is they can take it out. And post-operatively, they have a space missing in the brain where that was taken out. So usually you do not put them on the operative side, but make sure you always check the physician order. Where can I turn this kid? How high can I elevate the head? Can I turn them? Very important things, because you can create damage in that brain by turning them or having them too high. Again, we are worried about fluid balance. Too much fluid going to the brain. I mean, we give IV fluids, we could overdose them, right? It's dangerous. So this is overhydration. So again, intake, output, daily weights, protect the head. Muscular dystrophy, when we talk about it, they always are talking about Duchenne muscular dystrophy. Duchenne muscular dystrophy is mostly boys, ages 3 to 7, and they are cognitively delayed, even as infants, yes, but they might get up and try to walk, but by the age of 3, they're falling and they're starting to waddle where they've stopped not doing that. And you're going to see big hypertrophic calves and your upper arms, like big muscles. Why? I guess they're trying to get where they need to go. I'm not sure, and they can't. But these children, it is a progressive muscle weakness. And what usually happens with Duchenne is the muscle, your heart, and the diaphragm stop working. So heart and lungs as teenagers, and they die. It fails. So features of Downs, we know the almond eyes, we know the nose, it causes upper respiratory. We can have cardiac conditions, right? Scissoring is all about cerebral palsy, and they're moving their legs, right? 2 nursing priorities with myelomeningocele. Well, I've mentioned urinary problems, right? We want to make sure they're urinating and also checking their brain for hydrocephalus. And signs and symptoms of increased intracranial pressure, decreased heart rate, elevated blood pressure, where things like dehydration is the opposite of that. A newly shunted child, what should you check? They need to know, how high they need to be when they're sleeping or when they're sitting, and signs and symptoms when the shunt don't work. I mean, many kids that have shunts coming into the ER, they come in with vomiting and headaches, and that sign of pressure going on in their head. 3 main goals of providing nursing care for a seizure. Well, if you're having a seizure, number 1, turn them to the side, they're going to vomit. Number 2, you're going to clear the area of anything that could hurt them. Put the head down, get help. Side effects of phenytoin. Do you remember the gingival hyperplasia, acne? These are parts of it. Signs and symptoms of a child with meningitis. Well, the meninges is upset, it's irritated. you're going to have headaches and vomiting and fever. Antibiotics, we're going to be using, your penicillins for that. And then after surgery for brain tumor, we never put it on the side where the tumor was. Nursing interventions increase intracranial pressure. Think about fluid balance. Suctioning is part of it. Any tactile stimulation can increase it. And Duchenne muscular dystrophy comes from mommy, the X-linked recessive gene, actually. And Gower sign is what I do every day when I try to get up off the floor. I put my hands up my legs to stand up. And I'm sure sometimes many of you do that too. Okay, renal disorders. We're getting there, guys. A lot of information. Acute glomerulonephritis. This is caused when all of a sudden you stop urinating and then you have this dark tea-colored urine, bloody brown, hypertension, and you're swollen up all over. It's due to a strep infection that was not treated completely. And all of these things are reversible. It's usually when they start seeing the edema and they're not urinating is when these parents bring these children in. Now, this ASO titer, anti-streptolysin, look at the word in the middle, strep. What it does, it measures strep in the blood, an ASO titer, something that they'll look at if they can't remember. And of course, how do you measure kidneys? BUN, creatinine, right? And of course, if they've had a strep infection, if you remember it, but it's edema, you round the eyes, even the tongue, the mouth, all swollen. You'll see that. And these kids they just feel miserable. What do we do? Well, what does it due to? It's due to a strep infection, right? So we're going to be giving the antibiotic for that. But we're going to be monitoring that blood pressure, making sure it comes down. It has to do with the kidneys. What do kidneys do? Fluid balance, intake, output, daily weights, right? And then these children will be put on low sodium diet and fluid restrictions because we want those the fluid to get rid of it. Well, sometimes they do put them on as they're treating it, some sort of antihypertensive medication, depending on how high that blood pressure goes. And they will be monitoring for seizures. Usually, we can turn it around and it doesn't become chronic. It's only an acute stage. We can cure it. Now, as a hint, decrease in urinary output is the first sign of renal failure. And we know that specific gravity, the kidneys can't control it anymore, doesn't know how to filter anymore. And we know failure is when at least 50% of the function has gone. Now, nephrotic syndrome has nothing to do with kidney failure. Nephrotic syndrome is not kidney failure. The kidneys are working. But you know what happens? It says, protein, I don't like you, yuck, puts it in the urine and you urinate it out. So all the protein in your body goes away. What is protein there for, right? So protein is intravascularly. It has to do with giving medications. The protein albumin is the same name as protein. And what happens is your intravascular and your extracellular space, it tries to make an equilibrium and fluid is pushed out into the tissue. So you have a lot of edema around the eyes again, the tongue, the cheeks, everywhere. These kids don't feel good. They don't want to eat because they're chewing on their tongue and their cheeks because of all the swelling here. You will see massive, massive proteinuria. And if we looked at the protein in the blood, the albumin levels would be extremely low. And lipids go up. It just keeps the lipids in there. So again, nephrotic syndrome has to do with fluid balance. So what are 3 things we're going to do? Intake, output, daily weights. I think we're getting the hint here. All right. These children with nephrotic syndrome are immunosuppressed, so watch for infection. And these children, they're tired, they got extra fluid on them. They're going to be given steroids. It's actually the treatment for this. And these children need good protein diet with low salt. We don't want to get them bigger with carbs. So it's more of protein we give these children. And these children, again, when they go home, the parents need to be taught and the child weigh them every day. Now, urinary tract infection, most common of all GU issues in children. And we know there's certain things you see. One of the things as a nurse working in an ER for the last 10 years of my career, children would come in complaining of not eating and a fever and vomited once. And the doctor would say, here, do me a urine. And many times it was urinary tract infection. Children, when they don't feel good, what's the first thing they do? They stop eating, they stop drinking, they stop playing, right? So when we start to see those things, then we have to put the pieces together. What is it? We might see the strong smelling urine, the frequency, and all of that. We may not, okay? So any child who looks sick, that's the first thing we're going to check them for, believe it or not, because it is the most common. We know that frequent urinary tract infections could be due to structural issues. So if it continues, many of them need to be looked at. We need infants, we will do a catheterized specimen. And why would we do that to that poor little infant? Well, infants don't have an immune system. They have minimal immune system. And we want to go with one antibiotic and cure the infection. Then we want to have to go back 2 or 3 times with a different antibiotic. So getting a really good specimen is important. Of course, those clean catch things are good for older kids because their bodies can tolerate that. So no bubble baths. Increasing fluids are big. The acidic oral, the apple and cranberries are good, okay? And always teach them to wipe from front to back. Wilms tumor. Wilms tumor is a tumor on the kidney. I've seen one in my career. Wilms tumor, this boy's younger, African American, during the Haitian earthquake, it's 10, 12 years ago, our hospital went there for outreach, and we found this little boy, and through religious groups, we got him sent over an airplane, and this group picked him up and brought him directly to the triage at my hospital. Of course, I'm the triage nurse. I'm like, so why is he here? And they go, I don't know. They just told me to pick him up, bring him here. Here's the information. It was all in French. I don't speak French. So no idea. So what did I do? Well, first of all, I had to get on this child's level so he did not be afraid of me, right? Most important thing. I think I had some stickers, and I just sat down below him. I made him feel comfortable. We did a set of vitals. Then I started listening, the lungs. I started listening to the abdominal bowel sounds. And on the left lower quadrant, I felt a softball-sized tumor. And for some reason, I knew it was a Wilms tumor. The problem with Wilms tumor is they're very fragile. And if you touch them, manipulate them too much, pieces will break off and they'll metastasize. So they can do surgery after chemo. They can get it out. These kids do well because they take the whole piece out. But our goal is we're not doing a biopsy and we are not going to be touching that belly as much as we can, okay? Now, Hypoepispadias is a male born, and the urethra doesn't come out to the tip of the penis. The hypospadias is underneath somewhere. Could be up top, down to the base, it could be anywhere. Epispadias is on top somewhere. And usually before potty training, if they tried to do it by then, is to do a surgical correction. And they use the foreskin as plastic closure. They create a lumen. They put a catheter there to open it up. And all we need to do is keep that catheter inside the diaper. We don't do anything. Don't touch it. Don't roll it. No ointment. Nothing. Leave it alone and just let it drain. And they usually about 10 to 14 days take it out. Renal failure. Look at the cause of acute dehydration. That's how severe it is. Or it could be some obstructions. Many times congenital renal failure is congenital abnormalities. They're born with it. Or look, frequent infections. So renal disorders. Acute glomerulonephritis. What do you see? Hypertension, that dark red-brown urine, weight gain, we'll see swollen eyes, edema, right? And how do we take care of that? Intake, output, daily weights, right? And steroid antibiotics, because it's due to a strep, okay? So the antecedent, what happens before, is a strep infection. Acute glomerulonephritis, again, it's going to be low sodium fluid restrictions because they're already holding all their fluid. Hypoproteinuria and nephrosis is because we're getting rid of all the protein in the urine, right? And whenever we give steroids, we always taper it, right? We don't want to go from big dose to zero because it could cause big issues with our adrenal glands, and we always taper that off. Urinary tract infections, they say put little girls in cotton underwears, right? Little boys, pull back the foreskin, clean, the schmegma out at least once a day. No bubble baths, wipe front to back, right? These things. Wilms tumor, again, do not palpate the abdomen. And why do we do these corrections on this little penis for hypoepispadias before they go to school? Is, well, number one, they even want to do it before potty training so that their penis is squirting in the right direction. Now let's go to some GI. We're getting there, guys. Cleft lip, cleft palate. The big issue is infants explore the world and they relieve stress with their mouth, right? If you got a cleft lip, cleft palate, it's going to be hard to eat and it's going to be hard to have, you don't get the suction motion to keep that pacifier in. A lot of it, because it's all draining in there, and it's hard to get where it needs to go. There are going to be some coughing, aspiration into the ears, ear infection. Of course, that causes hearing loss. And it could cause one of the things with especially the palate is speech. That's why we try to get these done before they're a year old. Don't have to go through all of that social stuff that goes on with them. Parents who see their infant with a cleft lip, it's not pretty looking, but if you can show them what a kid looks like when it's done, they look normal, is what they need. Esophageal atresia, tracheoesophageal fistula, that means the fluid is going into the lungs because there's no stomach or because there's a connection between the esophagus and the trachea. Our big deal here is nothing to eat or drink, nothing. Even drops of water will go directly into the lungs. So we're going to monitor how they're breathing, okay? Elevate the head of the bed, have suction there. If they need oxygen, do it. And because this kid can't eat, the one thing that I tell you how they comfort themselves, stress relief, put a pacifier in their mouth. This is a child who would need it. Pyloric stenosis, I've seen it 3 weeks to 3 months. That is the age, and actually the sweet spot is 7 to 8 weeks, where they cannot eat. It doesn't go down their pyloric stenosis, doesn't get into their small intestines, and all of a sudden you'll see it, boom. And I'm telling you, this vomit is across the room, like 10, 15 feet across the room. It is quite impressive. Now, get an infant in young, and you'll ask them, so how are they vomiting? Is it dribbling or is it, projectile? I mean, across the room. If they say it's across the room, take your hand right underneath the xiphoid process. You're going to see a little olive, or I call it a marble. It's this hard area, and that's the hypertrophic valve, the pyloric valve, and you could feel it there, okay? We always worry about they're not getting fluid, dehydration, they're losing acid. Yes, we're worried about all of that, metabolic acidosis, but immediately make the child NPO. They get their ultrasound, they get an IV in because they're young. They need to have their sugar. Get them to the OR, and then afterwards, they can start eating about 4 to 6 hours afterwards. And usually they start with Pedialyte or glucose water, and they'll start to eat. And usually within 2 days, they're home. Again, we're concerned about eating and fluid status, daily weights, intake, output. Intussusception. Swim the intestines. These are usually toddlers, and they suck into each other. And because of all the nerves, it hurts. And it could go in and then pop out, and it's gone. You'll see the kid, the legs are going to be like going crazy, and they're crying. They are miserable. Then all of a sudden, it will pop out and be gone, and the kid's running around the room like a normal child. You're like, okay, this is one of those intussusceptions where maybe putting them on a diet, making sure they're eating to get the food going through, can keep it from happening again. Now, whenever I see these children looking like that, if they have a diaper on, I'm going to check it. Because there's like currant jelly. It's like mucus with maybe some shreds of blood in it. And that is one of these sides, one of the symptoms is currant jelly. And you'll see it like little gooey in their diaper. And they'll just do ultrasound. Many times it's a barium or an air enema will take care of it, and they do well. Nutritional needs, again, electrolyte imbalances. Remember, dehydration, electrolytes, we're always going to be identifying that with our young children because it is very serious. Now, Hirschsprung's. Hirschsprung is an aganglionic megacolon. What does that mean? Well, that means the ganglions are nerves. There's no nerves in the descending colon. That means no paracelsus, and you don't feel it. And it's filling up with, you already have mucus, acid, stomach acid, that's normal. And it is filling up in this area on the descending colon. And you're going to see no stool for 1 or 2 days on a newborn infant. Usually you'll see stools almost right at birth, right? That sticky meconium stuff, but you don't see it with that. Now, Hirschsprung's, the big thing is nothing needs to go on that rectum. No temperatures should be done that way. And these children need that piece of intestines that's dead to be removed. And they make a colostomy. And usually by the end of 1 year, they close it up. Appendicitis. Appendicitis is that right lower quadrant, McBurney point, where we see that the appendix is angry and it wants to come out. These children, if they're in pain, you send them to the OR, you're actually good. The appendix is still intact. If the pain stops, most likely it's burst. And our biggest fear then is peritonitis. Celiac disease is a nutritional problem from the small intestines. They have an intolerance to gluten. No wheat, rye, barley, or oats. So what would you feed them? Rice. They have rice flour and rice stuff like crazy today. You're going to see fat again. Don't like fat. Fat's not going to be absorbed. Because of it, big distended abdomen with gas and cramping. I'm telling you, these stools stink. They're the most foul smelling stools. Even worse than some GI bleeds. The steatorrhea is that fat that you see with diarrhea because they're not getting nutrition. Anorexia, right? Growth failure and maybe some cognitive problems. Now, maintain a gluten-free diet. They can have dairy, they can have meats, they can have fruits, they can have vegetables, they can have rice. There's things that can be done for these children. Gastroenteritis is just like diarrhea, right? That's what it is. What's our concern? Dehydration, fluid, electrolytes imbalance, right? So intake, output, daily weights are going to be things that we're going to watch. Always washing hands with any sort of itis of anything, of course. And they're saying with gastro, no fruit juices, soda, or sugary drinks. What they want you to do is give things like the Powerade, Gatorade, and many times they'll tell you to half strength it because of all of the sugar. They have sugar-free today. Sometimes they'll tell that. I can't tell you how many kids have come in with Pepto-Bismol, the little pink lips when they come in with gastro. You should not give those to children. How do we treat gastro? Well, feed them. Give them fluids. If you don't feed them, the stools are just going to keep watery, okay? Feed them, give them fluids, but a very easy diet, okay? And they give them at the hospital, tell them lactobacillus, to put that bacteria back. So cleft lip, cleft palate, there's so many neat things they have today to feed them. They've got bottles that you can sort of squeeze as they're eating. It was developed by a mother. We also have sitting up, holding the chin, suction at the bedside because they can aspirate. They don't have a palate to come out their nose because that's where the nose is, underneath on top of the palate, right? Signs and symptoms of TE and TEF. Well, that's that gagging and choking and cyanosis, right? Because it's going in the lungs. So what do? Well, these children, we make NPO. We start an IV to give them fluid because they need the sugar. And we give them antibiotics because they're having still, even with a little mucus in their mouth, they're having mini aspirations going on there. And those mini aspirations can cause an infection. So we give antibiotics for that, okay? So those are things that we would do for TEF and a pacifier. Barium enema or air embolus, air enema, intussusception, it just pushes out that intestines. It's usually done with radiologists at the bedside when you have that. Hirschsprungs, what do? Well, this is a megacolon, right? It's an aganglionic megacolon, Hirschsprung's disease. And preoperatively, we're going to get that child ready and prepared, parents ready for a colostomy. We don't eat them. We're taking out that piece. What care is needed for a child with a temporary colostomy? Well, this kid's going home with parents. We need to teach parents. We need the ostomy nurse to come. There are some nurses who love ostomy care, and that's what they do, and they're really good at it. Anorectal malformations, we have stool going in places where it shouldn't, okay? And priorities for a child undergoing abdominal surgery. Remember, post-op, you need to turn, cough, deep breathe, give pain medicines, etc. So let's do some hematology stuff now. Iron deficient anemia. Some of you had answered that with sickle cell, you need to give iron to. Sickle cell has nothing to do with iron depletion, okay? It has to do with the type of cells that are there. So when we look at it, iron deficiency is not enough iron in the body. And when the body doesn't get enough iron, the heart works too hard to get the iron and the oxygen around to the cells. And it burns calories. These kids are small. So these are the levels that you would do. There's things that we can do. If they're young infants, of course, that one's going to be getting those oral or even some IM iron we could give. Remember, if you give iron, you never give it with milk. You only give it with like orange juice, acid type stuff. And it should be on an empty stomach because the gastric juices breaks it down, okay? If they're older, they should be eating something for rich in iron. Meat, green leafy vegetables are the big thing. Hemophilia. Well, some kids are bleeders. They just bleed. You need a certain amount of factors in the body that stops bleeding once it occurs. There are children that are missing a factor 8, factor 9, von Willebrand's, their platelets, something. They don't have enough. And what would you see? You'd see children bleeding, bruising, petechial rashes, even the gums bleeding, when they brush their teeth. What do we see? Well, is a prolonged PTT. Well, what's the other thing that increases the PTT? Heparin, right? And what does heparin do? It thins the blood. It's the same thing what happens here with hemophilia. These children, parents do give their factor at home. There's a way to do it. And I've seen a father give his son once in the emergency room. He said, "Can I do it for him?" I'm like, "Sure you can." And I watched, and he did a great job. And the child actually helped them pick a vein and everything. Remember hemophilia, if you have a child just diagnosed and they're a toddler, make sure we pad stuff so that they're not hurting themselves or cutting themselves, and they should be identified in some manner. Remember, sickle cell is just the cells. You become crisis when you're dehydrated. It all backs up and then blood can't flow. The biggest thing with sickle cell is hydration. So supplemental iron is not given because it has nothing to do with iron, okay? We just give folic acid. Acute lymphocytic leukemia, cancer of the blood, the white cells, right? And this is about 80% of them. So we know that there are white blood cells, but they're immature, they don't work. These children are at risk for infection. They usually come in with pain, bruising, fever. They just don't feel good. There are 4 phases of treatment, and this is for the chemotherapy. And the induction is they hit these children with 2, 3 different sort of chemotherapies, big doses for like 4 to 6 weeks. And the goal is actually remission, which means you're knocking it all out. The cancer cells maybe are gone, but because you don't want a maybe, they go a little further to make sure any little cell is gone. One of the things is if you're administering some drugs, they have a high potential for anaphylaxis. So always have epi and oxygen ready, and it's asparaginase. That's the one that we see a lot of reactions to. And many times what they're going to do is give prednisone, and that helps a lot with these children. And allopurinol is actually used for gout, okay? But they use it to prevent problems with uric acid. What is gout? Uric acid problem. So Information of families being given oral iron. I've told you, empty stomach, never with milk, and we should give it with orange juice is your best thing. Dietary sources of iron, meat, green leafy vegetables are two of the best. Hydration, keeping those vessels open, and sickle cell keeps those weird shaped cells moving. How do we avoid it? We prevent dehydration. If they have an infection, they need to call their doctor right away. And what do we do for leukemia? Well, of course, it's that chemo, and then we're going to protect them from infections. Now your thyroid, I mentioned it a little bit earlier. It's the same thing that we do for adults, but the big thing is that these children need it for their growth and cognitive awareness. And you can see it, those complications of it. I mean, if you see a kid who's too quiet, too down, suspect. You might see it later on when they're not lifting their head, because that's the first thing they do on their gross motor, or even reflex palmar. If they're not doing it, needs to be checked. And these are the things. I mean, in adults, we have constipation, coarse hair, cold intolerance, but we know that hypothyroidism. I've gained weight because I'm hypothyroid, right? That's why I'm heavier. We've heard that. Or, yeah, I'm hyperthyroid because, I burn off calories like crazy. But these are the things that you would see. And we are concerned a lot about this hypothermia, that coarse hair, that the parents want their kids to have that beautiful hair, right? So they do a lot of screening before they go home. And actually, one of the symptoms of hypothyroidism is the constipation. If a newborn has not had a bowel movement in the first day and a half, they're going to be testing T3, T4, TSH. They're going to be checking it. And of course, teaching the parents what to look for, cognitive awareness, right? And constipation. And then making sure that they're taking, if they're given thyroid replacements, they are taking it the way that they should. And it's going to be forever and ever. And thyroid hormone for hypothyroidism should be given in the morning because it does give them a little boost, okay? Now, again, monitoring for constipation. And, the thyroid hormone, when it's too much, can elevate the heart rate. So we're going to be checking for that. Did we give too much thyroid medicine, right? And of course, that lethargy, etc. And these children need periodic testing. Now, phenylketonuria is why we do those little red dots, right? And we're looking for a metabolic issue. And that metabolic issue, we'll check there, and it's going to be a different sort of diet that they do need, because if not, it's going to cause a central nervous system, cognitive impairments, etc. So it is a special formula, phenol-free. And one of the things that we need to be aware of, NutraSweet is one of those things that can't have. So it's a whole diet, like would be the celiac disease. Diabetes, what do you see? Polydipsia, polyphagia, polyuria. I'm thirsty, urinating, and because I do not metabolize sugar, I'm hungry, hungry, hungry. And one of the symptoms is they start bedwetting at night where they're previously been continent. So children diagnosed with diabetes when they are young are type 1. They do not change to a type 2, okay? Type 2 might be your adolescent, which was overweight, could have been that contributing factor. And that one could be turned around. But once you're type 1, you are 1. How do you diagnose congenital hypothyroidism? Well, cognitive delays, growth, constipation, all of these things that you will see. Outcomes of untreated congenital hypothyroidism is that cognitive and growth failure, right? It's all about growth, growth, growth. Let me see. Classic signs of diabetes is those three: polyuria, polydipsia, and polyphagia. And what is hypo and hyperglycemia? Hypo, not enough. Hyper is too much. And how do we treat a child with diabetes who comes in with ketoacidosis? If you have ketoacidosis, you also have hyperglycemia, because ketoacidosis, the body is trying to find something to eat, and they're going to the proteins and into the fats, okay? And we do need these children very aware of blood sugars and testing them. They can be normal kids, but they have to monitor their blood sugars. Now, fractures. Fractures is any injury to a bone, right? What do we need to be most concerned about? And that's that growth plate, right? That growth plate could crack, and we need to get it fixed straight, or it's going to be a short arm, leg, finger, toe, because we didn't make it correctly straight. We need to look at the 5 Ps when we're ever assessing any possible fracture: the pain, pallor, pulsiosus, paresthesia, and paralysis, okay? Now, if a cast is put on, and if it's too swollen and we're seeing, the pain, the pallor, etc., they need to get to their healthcare provider, to the ER, wherever quick. They need to loosen that cast off to let blood flow again. Now, traction is used. The big thing is that if it's a hanging traction, that it hangs there, free swinging, and that you document the weights. So, HESI hints. Some of them are skeletal. There's pins. Always monitor for infection and pin care. Skin traction never, ever is removed, because then the bone will shift, and then you've taken away all that good work. And know that kids, they don't say they are in pain because they don't want a shot, okay? Know that some kid fractured femur hurts. They need something. They need to take something. Dysplasia of the hip. So the hip, the femur bone should go into the hip socket, but it's up top. So that leg is shorter. And if we look at the buttocks, one is up. We call unequal folds in their buttocks. And if we are taking, like the doctor does, put the knees up and down, you're going to hear this clicking. So how do we treat it? It's called a Pavlik harness, and there was several questions on Pavlik harness on the last HESI. And we only remove it for bathing, and it abducts the hip into position, okay? So only take it off for bathing. We need to put something underneath to maintain skin integrity, okay? Scoliosis, that S-shaped curvature. If it is, not that big of a curve, what they'll do is they'll see the hip will be in different lengths, and they'll see that they're bending over. They'll see one arm could be a little bit longer too. And what do? It's another brace, 23 hours a day. Take it off to bathe. And again, a shirt underneath and the brace on top. And the hardest thing for these Milwaukee braces, scoliosis, is usually your adolescents. And we know that this body image, they don't like it, okay? When and if they need surgery, this is a child or adult, because some of them get that old, that you need to do log rolling on, because they put a metal in the spine, so you need to keep it straight. This is a log roller that you would do. Juvenile rheumatoid or juvenile idiopathic arthritis, the body attacks joints. So how do we treat it? Well, keeping it moving, keeping it exercising. taking non-steroidal and anti-inflammatories like ibuprofen, naproxen. Sometimes it's anti-rheumatic drugs like, Humira or methotrexate, or a combination of all of them. One of the side effects that, we don't think about is erocyclitis, and it has to do is eyes turn red, and it could cause vision loss. So this child must go to the doctor and check their eyes. You give corticosteroids in those crises when it's flaring. You can't give it every day for it because there's all too many side effects with it. So neurovascular assessment, what do you check? You have a cast on, you're going to check, for the P's, right? Those 5 P's. Compartment syndrome is when there's swelling, blood's not flowing, all right? Epiphyseal plate, growth plate. We want that arm, leg, toe, whatever to grow normally, right? And that skeletal attraction. And if there's pins, we do pin care. If it's pulling just on skin, making sure those weights and those pulleys are free hanging there. Spica cast, you can't get it wet, and you try to keep it as clean as possible. And what is this congenital dislocated hip? It's that positive Ortolani sign. There's these clicking going on. We'll see a shorter leg, and the gluteal folds will be crooked because the hip is not where it should be in the socket. It's up high. And that is the end of it. This is all from your book. This is your PN-NCLEX book. It is long. There's a lot of information there. I just hope I hit on some things that you didn't get and that you can understand now.